Please start, madam.
Okay, sir. Thank you so much. Good evening, students. Today we'll be discussing about abdomen. So first we will introduce the topic, and then we will discuss about the anterior abdominal wall, the celiac trunk and its branches. So the abdominal cavity, as we all know, it is separated from the thoracic cavity by the diaphragm. So this abdominal cavity above the pelvic inlet, it is known as abdomen proper, and below the pelvic inlet, it is known as the pelvic cavity. And the abdomen, this is the anterior abdominal wall, and this is the posterior abdominal wall. Now, we will see the boundaries of the anterior abdominal wall. So this is a xiphoid process and this is a coastal margin. So if you trace the xiphoid process and the two coastal margin, then the mid-axillary line, what you're seeing here is the mid-axillary line, and anterior aspect of the iliac crest, then up to the pubic tubercle, pubic crest and the pubic symphysis. So this is the tracing of the anterior abdominal wall. Now we will see the surface anatomy of the anterior abdominal wall. As you can see here, this is the median groove, and this median groove is interrupted by umbilicus. This umbilicus lies at the level between L3 and L4 in adults. In case of newborn, the level of the umbilicus is slightly lower. That's because the pubic region is, the pelvic region is not well developed in the newborn. Whereas in case of old age, what happens is the level of the umbilicus is slightly pushed down because of the atonicity of the muscles of the anterior abdominal wall. So this is the median groove. Underneath the median groove, there is linea alba. So this is the linea alba underneath the median groove. Now, laterally, this is the linea semilunaris. So laterally on either side, there is the linea semilunaris. So this is the linea semilunaris. So this extends from the tip of the ninth costal cartilage till the pubic tubercle. Then what you're seeing here is the tendinous intersections. So that is the tendinous intersection. This muscle here, that is the rectus abdominis. So this is the rectus abdominis muscle. Now we discussed that this is the median longitudinal groove underneath which is present is the linea alba. The extent of linea alba is from the xiphoid process till the pubic symphysis. We will discuss about it later. Now, this rectus abdominis muscle, that muscle is enveloped by a sheath which is known as rectus sheath. The rectus sheath is attached to the muscle in the form of tendinous intersections. So that is about the surface markings. Now, the anterior abdominal wall is divided into 9 regions by 2 horizontal and 2 vertical planes. This horizontal plane, what you're seeing is the transpyloric plane. It is the transpyloric plane. So, this plane is referred as subcostal plane by some authors, but in view of the MCQ question, we will discuss about the transpyloric plane. This transpyloric plane, it passes through the ninth costal cartilage and it passes through the lower border of L1 vertebrae. This is frequently asked MCQ. They will ask the structures which is present at this plane. So this is a transpyloric plane which is passing at the ninth costal cartilage and it cuts the lower border of the L1. This what you're seeing here, that is the transtubercular plane. This transtubercular plane is passing at the upper border of L5. So it is passing at the upper border of the L5. So if you join the two tubercles of the iliac crest, you will get the transtubercular plane. This is an MCQ question, which is passing at the upper border of L5. Another MCQ question, transpyloric plane is passing at the lower border of L1. Now, the two vertical planes passing through the mid-clavicular line to the mid-inguinal point. That is in between the anterior suprailiac spine and the pubic symphysis. That is the mid-inguinal point. So if you join those 2 points, you will get the mid-clavicular plane. So in this manner, the two horizontal, that is the transpyloric plane and the transtubercular plane, and the two vertical plane, the right and the left mid-clavicular plane, will divide the abdomen region into 9 quadrants. So what are the quadrants? Umbilicus is present here. So this is the umbilical region. Above is the epigastric region. Below the umbilicus is the hypogastric or the pubic region. Hypogastric region. On either side of the epigastric is the right and the left hypochondrium. On either side of the umbilicus is the lumbar region. On either side of the hypogastrium is the iliac region. So these are the 9 quadrants. So the MCQ question asked here is transpyloric plane. Transpyloric plane separates what and what? Obviously, as you're seeing here, it separates the hypochondriac region from the lumbar region. Another few MCQ question asked here is transpyloric plane passes through the 9th costal cartilage and it passes at the lower border. It passes at the lower border of L1. And the next one is the transtubercular, which passes at the upper border of L5. These are some of the MCQ questions. The other MCQ question what they will ask is, what are the structures present in this transpyloric plane? So in this transpyloric plane, what are the structures you encountered? This is the MCQ question, for which the answer will be in this region. You will have the pylorus of the stomach. So you'll have the pylorus of the stomach. Then you will have the hyla of both the kidneys. Then you will have fundus of the gallbladder, and then superior mesenteric artery. So this is again an MCQ question. We will see the next slide. So transpyloric plane, as already discussed, it passes through the 9th costal cartilage at the lower border of L1. What are the structures here? You can see the gallbladder here, fundus of the gallbladder, hyla of both the kidneys. Then you have the pylorus of the stomach. Actually, this has to be the mesenteric artery. So these are some of the structures which you encounter in the transpyloric plane. And this now we will discuss the MCQ questions. Students, are you all there? Okay, we will discuss the transpyloric plane. Are you able to hear me, students?
Yes.
Okay.
Yes, ma'am.
Okay, pa. Yes. So the transpyloric plane, you all know the transpyloric plane, it separates. So this was the midclavicular line, transpyloric, transtubercular plane, transpyloric, transtubercular. Then these are the midclavicular line. Then we have the epigastric, umbilical, hypogastric. Then what is this? Hypochondrium, lumbar, and the iliac. So we are discussing about the transpyloric plane separates hypogastrium from the lumbar region, hypochondrium from the lumbar region, iliac fossa from the lumbar region, umbilical region from the lumbar region. What is the answer, students?
Option B.
Excellent. Okay, so that's the option. Now, transtubercular plane lies at which vertebral level? Transpyloric, transtubercular, transpyloric. Where does this lie, students? What is the option?
Option
L1?
C.
L5, C.
Excellent. Yeah. So it passes through L5. So that is the answer. Which of the following structure is not present within the transpyloric plane? Is it L1? Is it the fundus of the gallbladder? Is it the hilum of the kidneys or the inferior mesenteric vein? Guess the answer, students. So transpyloric plane, it
Option
was excellent.
Lower border.
Yeah, so I'll explain this. We know that the transpyloric plane was passing at the lower border of L1. So this is also correct. What were the structures we studied? Fundus of the gallbladder. Then we studied the hyla of 2 kidneys. Then we studied the superior mesenteric artery. So this is the wrong option. Okay. Then iliac crest lies at the level, the highest point of the iliac crest. So what do you think is the answer, students? L3, L4, L5 and S1. You may guess, I will explain it.
L4.
Excellent. Excellent. See here, you have the iliac crest of the hip bone, right? Its highest point lies at the spinous process of L4. In some textbook, it is mentioned as L5. That is because it is at the spine of the L4, but higher textbook says that the iliac crest at the highest point is L4, the spine of the L4. Excellent. That's the answer. Not present at transpyloric plane. One more similar question. L1, right suprarenal gland, tip of the ninth costal cartilage, fundus of the gallbladder. What's the answer, students? Transpyloric plane, transtubercular plane, midclavicular plane.
Right suprarenal.
Right suprarenal.
Yeah, this is the answer because you know that transpyloric plane passed at the lower border of L1 and it passed at the tip of the ninth costal cartilage in the front, right? Fundus of the gallbladder, you know. So the answer is the right suprarenal gland. It is not suprarenal gland, it's the hila of both the kidney which is related to this plane. Now, we will discuss the anterior abdominal wall. So, the boundaries of the anterior abdominal wall we have already discussed. Now, we will go one by one structures. First structure what we encounter is the skin. So, the skin in the anterior abdominal wall is comparatively thin when compared to that of the posterior abdominal wall. The Langer's line, you have something called as the Langer's line. In the abdomen, it is horizontal. Now, what is the meaning of the Langer's line? So, the direction in which the collagen bundles of the dermis run, that is known as the Langer's line. In abdominal region, the collagen bundles of the dermis they will run horizontally. Now, what is the importance of this? Surgical importance of this is you make any incision along the direction of this Langer's line, you will not be cutting the collagenous bundle and thereby the scar formation is very minimum. So that is why mostly any incision you make, you follow the Langer's line. So that is about the Langer's line and the skin. Now the immediate next structure obviously you encounter is the superficial fascia. So the next structure is the superficial fascia. But for the superficial fascia here, you just have to draw 2 points here, anterior superior iliac spine. Draw both anterior superior iliac spine, draw the line. Above the line joining the two anterior superior iliac spine, the superficial fascia is one layer. But below the anterior superior iliac spine, the line joining the two anterior superior iliac spine here, the superficial fascia becomes two layers. So what are the two layers of superficial fascia? You have the superficial fatty layer, which is known as Camper's fascia, and you have the deep membranous layer, which is known as the Scarpa's fascia. So what did we say? We said that the superficial fascia is single layered above the line joining to anterior superior iliac spine, but below the line joining to anterior superior iliac spine, the superficial fascia splits into two layers. Superficial most is the Camper's fascia, which is fatty, and then deep to the Camper's fascia, you have the Scarpa's fascia, which is membranous. Okay, in the abdomen, you don't have deep fascia. Any idea why you don't have the deep fascia in abdomen, students? Why there is no deep fascia in the abdomen? Anyone, students? Anyone? Okay, I will answer. So, the deep fascia, what is the characteristic of deep fascia? The deep fascia is made up of collagenous fibrous substance which is not elastic. So, if at all nature had provided deep fascia in the anterior abdominal wall, the bulging would not be possible. So, that is why what nature has done, it has removed the inelastic or non-elastic deep fascia from the abdominal wall so that we can make any early diagnosis of some fluid accumulation or any pathology. That is why you don't have deep fascia in the anterior abdominal wall, mainly because of its non-elastic nature. Okay, so now what we have to do is we have to trace both the superficial Camper's fascia and the deep Scarpa's fascia. We will trace it now. It's important in clinical point of view. So we discussed that Below the two anterior superior iliac spine, the superficial fascia splits into two layers. Superficial fatty layer, you can see here, superficial fatty layer, the campus fascia, and the deep membranous scarpa's fascia. Now what happens is, the superficial fatty campus fascia, it becomes continuous with the fatty layer of the surrounding tissue. Then when you trace the campus fascia to the penis, the fat absolutely disappears from the campus fascia. Okay. Now the campus or the superficial fatty layer in the scrotum, it becomes a muscle which is called as Dartos muscle. Dartos muscle. Okay. So that is about the campus fascia. So that's about the campus fascia. I mean the campus layer. Now we will discuss about the scarpa's fascia. So scarpa's fascia, it is the deep membranous layer. We will trace this layer. So it continues, it becomes a tubular prolongation around the penis. Okay. Then it continues over the dartos muscle. It continues over the dartos muscle, and it becomes continuous with the fascia of the perineum, which is known as Colles fascia. And this Colles fascia is attached to the perineal membrane. Now, in between the perineal membrane and the Colles fascia, this space is known as superficial perineal pouch. Details of this we will be discussing in our next few classes. But for now, the space between the perineal membrane and the Colles fascia, this space is known as superficial perineal pouch. Now, what is the importance of this? So, what did we say? We said that the superficial layer, it has campus, fatty layer, and the deep membranous layer. The fatty campus layer in the region of scrotum, it became the dartos muscle, whereas the scarpa's layer, when you trace that, it became continuous over tubular prolongation over the penis. It continued over the dartos muscle. It continued along with the Colles fascia of the perineum, and it got attached to the perineal membrane. Now, what is the importance of this is, if there is any rupture of the urethra, what happens is the extravasation of the urine collects in what pouch is this? This is the superficial perineal pouch in between the perineal membrane and the Colles fascia. And this urine will enter into the scrotum. It will pass into the penis. It will pass into the space between the scarpa's fascia and the muscle underneath, which is that external oblique muscle. So in this way, the extravasated urine will pass. In extreme cases, this urine can accumulate up to the axilla. So that is about the extravasation of urine. Now, we will trace the scarpa's fascia laterally. So what happens? This is the anterior abdominal wall where urine has accumulated if there's any rupture to the urethra. Now, in the thigh, the deep fascia is known as fascia lata, which we have already discussed. Now we are discussing about the scarpa's fascia. So what happens is, this is the inguinal ligament. The scarpa's fascia attaches one finger breadth below the inguinal ligament. That is, the scarpa's fascia tightly gets adherent to the fascia lata of the thigh. Okay. So that line is called as Holden's line, wherein the scarpa's fascia becomes adherent to the deep fascia of the thigh, which is the fascia lata. And this Holden's line extends from the pubic tubercle 8 centimeters laterally. What is the importance of this is, urine can accumulate till the Holden's line, not below that, because the scarpa's fascia is adherent to the fascia lata of the thigh. That is why the urine cannot extend beyond the Holden's line. Now, we will see the midline expansion of the scarpa's fascia. What happens? We already discussed, this is the umbilicus, median groove, underneath is the linea alba. So, the scarpa's fascia attaches to the linea alba MCQ question, and then it becomes continuous as the suspensory ligament or fundiform ligament of the penis. It becomes the suspensory ligament or the fundiform ligament of the penis. So that is about the fascia, scarpa's fascia and the campus fascia. Any doubts, students, here? Can we proceed?
Yes, ma'am.
Okay, we will proceed. Okay, pa. So now we will discuss the anterior abdominal wall. Now, The anterior abdominal wall, the muscles of the anterior abdominal wall, you have three flat muscles. Three flat muscles are present here. Outermost is the external oblique. Why it is called external oblique? Because this muscle, it is oblique. Can you see the fibers? It is oblique and it is externally placed. That is why it is called external oblique. If you cut off this external oblique on the inner aspect, you have internal oblique. Why is it called internal oblique? Because it is internal to external oblique and the fibers are oblique in direction. So first you encountered the external oblique, next you encountered the internal oblique. If you remove both this layer, you will have transverse abdominis. So why is it called transverse abdominis? Because the fibers are transverse in direction and it's a muscle of the abdomen. That is why it is called as transverse abdominis. So these are the flat muscles of the abdomen. So external oblique, internal oblique, transverse abdominis. Then a muscle you can see here is known as rectus abdominis muscle. Rectus abdominis muscle. Now what we have to just to know here is the rectus abdominis muscle is enveloped. It is enveloped by rectus sheath. Very important. So this rectus abdominis, it is enveloped by rectus sheath. What is this rectus sheath? It is nothing but the aponeurosis formed by three flat muscles of the abdomen. They will envelop this muscle, rectus abdominis, forming a sheath which is known as rectus sheath. We will discuss this in detail later. Now first we will discuss the external oblique muscle. As you already know, so these fibers are oblique in direction, that is why it's called oblique. It is externally placed, that is why it is called as external oblique. As you all can see, rectus abdominis muscle is hidden by the aponeurosis of these three flat muscle, and this is known as the rectus sheath. Okay, so basically rectus abdominis is enveloped by a sheath which is known as rectus sheath. Okay. Now we will see the origin insertion of these muscles, external oblique muscle. So first we'll finish off the outermost muscle, external oblique. So this muscle, it arises by 8 fleshy slips. Okay, it arises by 8 fleshy slips from the lower border and the outer surface of the lower 8 ribs. Okay, no confusions here. It arises from the lower border and the outer surface of the lower 8 ribs. After taking origin, the posterior most fibers are vertical. As you all can see here, the posterior most fibers are vertical. And where do they get inserted? I'm talking about the posterior most fibers. Now, before discussing that, what you're seeing here is the iliac crest. Iliac crest, as you all know, it is divided into ventral segment, ventral 2/3 and the dorsal 1/3, right? So now where is this external oblique muscle attached? Before that, the ventral segment of the iliac crest, this is the outer lip, this is the intermediate area, inner will be the inner lip. Now the external oblique muscles, posterior most fibers, they are vertical in direction and they are attached to the outer lip of the ventral segment of the iliac crest. Okay. Now we will see the remaining fibers. These fibers pass downwards, forwards and medially. Just imagine you're putting your hand inside your pocket. How do you put? What is the direction? It is downwards, forwards and medially. Then later what happens? It expands to form the aponeurosis to cover the rectus abdominis muscle and thereby it becomes the rectus sheath. Now we will see the other insertion. So the fibers are passing. Just imagine you're putting your hand inside your pocket. So it's passing downwards, forwards, medially. It is becoming aponeurotic. Can you see here? It's becoming aponeurotic and it is attaching to the linea alba. Okay, it's attaching to the linea alba. If you appreciate here, you can see that external oblique muscle is poorly developed below. It is fully aponeurotic. This is an MCQ question. We'll discuss it later. So the rectus abdominis muscle is enveloped by the aponeurosis of the external oblique muscle. We will see the modification of this external oblique muscle. But before that, we will just see, I said you rectus abdominis muscle. It is enveloped by the rectus sheath. So if this is anterior aspect, this is the posterior aspect. You have the anterior layer and posterior layer of the rectus abdominis. So one layer of rectus sheath you have already seen, that is formed by the aponeurosis of external oblique. So the anterior layer covering the rectus abdominis muscles, so that rectus sheath is formed by external obliques aponeurosis. We will discuss in detail once again. Now we will see the modification of external oblique muscle. It forms inguinal ligament, very important for your next class. So it forms the inguinal ligament. So inguinal ligament is formed by which muscle, students? Inguinal ligament is formed by, it is formed by external oblique muscle. So inguinal ligament is attached from anterior superior iliac spine to the pubic tubercle. So what happens is the fibers of the aponeurosis of the external oblique muscle, as it approaches the inguinal region, it folds backwards, forming this inguinal ligament. So if anyone asks you the inguinal ligament is formed by which muscle, your answer will be external oblique muscle. One more modification of this external oblique muscle. Can you see a small opening here? That is called as superficial inguinal ring. Very important. So, superficial inguinal ring, it's a modification of the external oblique muscle. Where is this present? Just above the pubic crest, you will have an opening. That opening is called as superficial inguinal ring. There's one more ring called as deep inguinal ring. We will discuss it later. So, modifications of external oblique muscle are inguinal ligament, superficial inguinal ring. What comes out of the superficial inguinal ring? Spermatic cord, right? So once the spermatic cord comes out of the superficial inguinal ring to reach the scrotum, it receives a sheath known as external spermatic fascia. External spermatic fascia. So what did I say? Inguinal ligament, superficial inguinal ring, they are the modifications of external oblique muscle. So once the spermatic cord comes out of the superficial inguinal ring, it receives a sheath which is known as external spermatic fascia. So if someone asks you external spermatic fascia is from which muscle, again that will be from the external oblique muscle. So this is all about the external oblique muscle. Now we discuss the next layer, the deep layer. So we have discussed the external oblique muscle. Now we will go to the next layer, which is the internal oblique muscle. It is called internal because it is placed internal to the external oblique muscle, and the fibers you can see it is oblique in direction. Now let us see the origin and insertion of this muscle. Now for the external oblique muscle, I said you have to imagine you're putting your hand inside your pocket. Now the fibers of internal oblique are exactly opposite. You have to imagine a handshake for this, okay? Which means that both the external oblique and internal oblique fibers are 90 degree to each other, okay? We'll see the origin and insertion of the internal oblique muscle. We already discussed that this is the intermediate area of the iliac crest, ventral two-thirds of the iliac crest. So, internal oblique muscle arises from. Now, before that, this is the anterior superior iliac spine. Imagine this is a pubic tubercle. So, this will be the inguinal ligament. So, what is the origin of the internal oblique? It arises from lateral two-thirds of the inguinal ligament. It arises from the intermediate area on the ventral segment of the iliac crest. It arises from a fascia that is called as thoracolumbar fascia. So what are the three origins of the internal oblique muscle? It arises from lateral two-thirds of the inguinal ligament. It arises from the intermediate area on the ventral segment of the iliac crest. It arises from the thoracolumbar fascia. After taking its origin, the posterior most fibers, they are going and inserting to the lower three ribs, lower three or lower four ribs. Now, what happens to the rest of the fibers? The rest of the fibers, they pass upwards and medially, and they become aponeurotic. Very important point here. We will see about the aponeurosis of the internal oblique muscle. So we discussed that this is the rectus abdominis muscle. Just imagine this is the rectus abdominis muscle which extends from the xiphoid process till the pubic symphysis. Okay. So we know that the rectus abdominis muscle is enveloped by a sheath. Rectus abdominis is enveloped by a sheath which is known as rectus sheath. Now, we have to see how the aponeurosis of internal oblique muscle will split to hug this muscle rectus abdominis. Now, you imagine this is the umbilicus, which is at the level of L3 to L4. Now, mark a point in between the umbilicus and pubic symphysis, midpoint between the umbilicus and pubic symphysis. So, from the xiphoid process till the midpoint between the umbilicus and the pubic symphysis, in between this area, the internal oblique muscle will split into posterior layer and anterior layer, and it will hug the rectus abdominis muscle, forming the rectus sheath. Okay. Then, so this splitting extends only till this region. What happens below this region? The aponeurosis of internal oblique muscle, it will not split, it will pass in front of the muscle. We will discuss it in detail when we come to the rectus sheath. Okay. But for now, the aponeurosis of the internal oblique, it splits into the anterior lamina and the posterior lamina in between the xiphoid process and a point between the umbilicus and the pubic symphysis. If this is this point, only in this region, the aponeurosis of internal oblique will split into anterior lamina, posterior lamina. Below this level, the aponeurosis just continues in front of which muscle? Rectus abdominis muscle. So hoping you will answer when we come to the rectus sheath. We will go to the next slide. So we discussed about the posterior most fibers which was gaining attachment to the lower ribs. We discussed that the remaining fibers passed upwards and medially and they splitted. The region also you know from where the aponeurosis split to enclose the rectus abdominis muscle. Now we will discuss about inguinal fibers. So you can see the inguinal ligament which is formed by the external oblique muscle. So let us discuss the inguinal fibers of the internal oblique muscle. If you imagine, this is the inguinal canal, right? Now, so we have the internal oblique muscle which is forming the anterior wall of the inguinal canal. So it is forming the anterior wall of the inguinal canal. It is forming the roof of the inguinal canal and the fibers are passing downwards and medially and it is forming the floor of the inguinal canal. That's called as a conjoint tendon. We will discuss once again. If you imagine this is the inguinal canal, the inner fibers of the internal oblique muscle, they will form the anterior wall of the inguinal canal. They will form the roof of the inguinal canal and the fibers will run downwards to form the conjoint tendon. We will discuss it later. It will form the conjoint tendon. So that is about the internal oblique. This was to show you that anterior the inguinal canal, it is formed by the internal oblique. Obviously, above the internal oblique, you will have aponeurosis of the external oblique muscle. Everybody here this? Am I audible to discussed? This is the external oblique muscle. This is the internal oblique muscle. This is the transversus abdominis muscle. So we discussed that the inguinal fibers of internal oblique muscle, they will form conjoint tendon after joining with similar aponeurosis of transverse abdominis. So conjoint tendon is formed by aponeurosis of both the internal oblique and transverse abdominis. You will appreciate it when we discuss the inguinal canal. Now, What is the other modification? So the external oblique, we discussed what was the modification. It formed the inguinal ligament. It also formed the superficial inguinal ring. Internal oblique, you discussed that it formed the anterior wall, roof, and the conjoint tendon. So conjoint tendon is formed by internal oblique as well as the transversus abdominis. Right? Now, we will discuss one more important thing, which is the cremaster muscle. Some authors say that the cremaster muscle is a detached part of the internal oblique muscle. Some authors say that cremaster muscle is formed by both internal oblique and transverse abdominis. Now what we will see is the cremaster muscle is in the form of U-shaped sling. Okay, it is in the form of U-shaped sling. It is formed by superficial anterolateral set and the deep posteromedial set. Anterolateral set, just listen, not important. It is formed by the middle part of the inguinal ligament. And these fibers will join with the posteromedial set and they will enclose the spermatic cord and they will reach up to the testis. You can see here the anterolateral set, posteromedial set. It is the cremaster muscle is in the form of U-shaped sling, which is covering the spermatic cord and extending up to the testis. Now, what is the importance of this cremaster muscle is, it is a defense mechanism. In case of raised intra-abdominal pressure, what happens is it contracts and pulls the testis towards the superficial inguinal ring. Okay, and there's also a cremaster reflex wherein when the inner aspect of the thigh is stroked, there is elevation of the testis. So that is called as a cremaster reflex. Now, one more important thing is they also say that this muscle helps in thermoregulation of the, it maintains the temperature of the scrotum. So that is about the cremaster muscle, which is mainly contributed by internal oblique as well as the transverse abdominis muscle. Now we will discuss about the transverse abdominis muscle. With this, we have finished external oblique muscle. We have finished internal oblique muscle. Now we are discussing transverse abdominis muscle. Now transverse abdominis muscle, obviously the fibers are transverse. Now let us see its origin. Its origin is, it arises from the inner lip of the ventral segment of the iliac crest. It arises from lateral 1/3 of the inguinal ligament. We saw that internal oblique arises from lateral 2/3, but transverse abdominis is arising from lateral 1/3 of the inguinal ligament, inner lip on the ventral segment of the iliac crest. It also arises from the thoracolumbar fascia. It also arises from the last 6 ribs. It also arises from the last 6 ribs, and the fibers run transversely and it forms aponeurosis. You can see here it is forming the aponeurosis. Now, in the inguinal region, what happens to this transverse abdominis is, we saw that in the inguinal region, anterior wall of the inguinal canal was formed by external oblique muscle as well as the internal oblique muscle. The roof was formed by internal oblique muscle and also transverse abdominis. So transverse abdominis muscle along with the internal oblique, it will form the roof of the inguinal canal and it will also join with internal oblique to form the conjoint tendon, which we have already discussed. So this was to show you the cremastric muscle, how it is enclosing the testis. Now, we have discussed about the external oblique, we have discussed about the internal oblique, we have discussed about the transverse abdominis. If you cut the transverse abdominis, underlying is the fascia transversalis. So you have the fascia transversalis. Okay. Now, so this is the fascia transversalis. When will you reach the fascia transversalis? If you cut all the 3 muscles, external oblique, internal oblique, transverse abdominis. So this is the transversalis fascia. Few MCQ questions have been asked on this. If you cut the fascia transversalis, you will reach the extraperitoneal connective tissue. If you cut that, you will reach the parietal peritoneum. If you poke the parietal peritoneum, you will reach the viscera. Okay. So now we are seeing the transversalis fascia, which is immediately underneath the transverse abdominis muscle. One of the modification here is there is a Deep inguinal ring. If you remember, superficial inguinal ring, can any student answer it was formed by which muscle, students? Superficial inguinal ring, it is formed by external oblique muscle. Deep inguinal ring is formed from, this is an MCQ question, it is formed by transversalis fascia. Now, where will you locate the deep inguinal ring? Deep inguinal ring is located around 1.2 centimeters above the mid-inguinal point. What is the mid-inguinal point? It is the point in between the anterior superior iliac spine and the pubic symphysis. So that point is known as mid-inguinal point. So 1.2 centimeters above the mid-inguinal point, you have the deep inguinal ring, which is nothing but it's an opening in the fascia transversalis. Now, a very important thing, this will help you for your next class. If you observe here, there is an artery here which is called as the inferior epigastric artery. If you see properly, this is medial. So, the deep inguinal ring is lateral to the inferior epigastric artery. Just remember, the opening of the deep inguinal ring, it is placed lateral to the inferior epigastric artery. Therefore, any bulge, any hernia here, that is known as the indirect hernia. We will study it later, but for now, you have to remember the deep inguinal ring is placed lateral to inferior epigastric artery. So that was about the transversalis fascia. Now, we will see the rectus abdominis muscle. So, as already discussed, rectus abdominis muscle is enveloped by a sheath which is known as the rectus sheath. Okay, so this beautiful muscle here is called as rectus abdominis muscle. We will see its origin and insertion. It arises, it has two head, medial head and the lateral head. Medial head arises from the pubic symphysis. Medial head arises from the pubic symphysis. Lateral head arises from the pubic crest and the pubic tubercle. Pubic tubercle and the pubic crest. Okay. So medial head arises from the pubic symphysis. Lateral head arises from pubic crest and the pubic tubercle. These fibers pass upwards and they are attached to the they are attached to the xiphoid process in the midline. The remaining fibers are attached to the fifth, sixth and the seventh costal cartilage. So this is the attachment of the rectus abdominis muscle. If you observe here, there are some tendinous intersection which is nothing but the attachment of the rectus sheath tightly into this muscle. These tendinous insertions, they make this muscle more powerful and they prevent the bowstringing during bending or some body movements like that. So that is about the rectus abdominis. Now next we will have to see the rectus sheath. So as already discussed, if this is the rectus abdominis which extends from, so we will see the rectus sheath. If this is the rectus abdominis muscle, what is the extent? Pubic symphysis. You just imagine pubic symphysis obviously is the medial head. Then we have pubic crest and pubic tubercle. It is inserted to the xiphoid process. Just imagine this part. Now, we know that the rectus sheath is nothing but the envelope covering the rectus abdominis. It has anterior layer and posterior layer. So it has two layer, anterior layer, covering back is the posterior layer. And you have the medial end and the lateral end. We will discuss everything. Now, this is the rectus sheath which is covering the rectus abdominis muscle. First, we will discuss the anterior layer. Anterior layer means in front of the rectus abdominis, the sheath which is covering is known as anterior layer. Behind the rectus abdominis, the sheath which is covering is known as posterior layer. This is the medial part of the rectus sheath. This is the lateral part of the rectus sheath. The medial part of the rectus sheath is attached to the xiphoid process to the pubic symphysis. Obviously, that is the attachment of the linea alba. The lateral margin of the rectus sheath is to the linea semilunaris, which is from the ninth costal cartilage to the pubic tubercle. Okay, now we will discuss the anterior layer and the posterior layer. So first, we will discuss the anterior layer. Again, rectus sheath is divided into various places. Now, we said that the rectus abdominis muscle was attaching to the xiphoid process and 5th, 6th and 7th costal cartilage, right? So this was the rectus abdominis muscle. Now first we will discuss the anterior lamina in the region of the costal cartilage. Let us see the anterior lamina in the region of costal cartilage. We discussed that the external oblique muscle arised from the lower 8 ribs, right? And the internal oblique muscle's insertion was to the lower 3 ribs. So this high, the internal oblique muscle cannot reach, right? So the rectus abdominis is covered above the costal cartilage only by external oblique muscle. I will show you here. This is the costal cartilage, 5th, 6th and 7th costal cartilage. Then you have the rectus abdominis muscle. This high only muscle to reach is the external oblique muscle. Obviously, what covers anteriorly? Aponeurosis of the external oblique muscle. So, this is the anterior layer in the region of the costal cartilage. So, it is formed only by one layer, which is the aponeurosis of the external oblique muscle. Now, we will discuss one more layer. Now, we have discussed the anterior layer near the costal cartilage. Now, what we will discuss is from the xiphoid process till the between L3 and L4, you know that there is umbilicus. So, from the xiphoid process to the midpoint between the umbilicus and pubic symphysis, if you take this as the midpoint, so the next level is from the xiphoid process to the midpoint between umbilicus and the pubic symphysis. Let us see the anterior layer of the rectus abdominis here. Obviously, we know that in this region, what happened? The internal oblique muscle split into two layers, anterior lamina and posterior lamina. So, here, this is the internal oblique muscle splitting into anterior lamina, posterior lamina. So, now you will tell me what is the anterior layer of rectus abdominis formed by? It is formed by external oblique and it is formed by anterior lamina of the internal oblique. Next layer we will discuss. Next we will discuss the third layer, the third part. So third part is in between the midpoint between umbilicus and pubic symphysis. So this is the third part. So here obviously what happens is we know that the splitting of the internal oblique does not take place in this region. Therefore, all the aponeurosis will pass in front of the rectus abdominis muscle. So this is the thickest layer. So this is the thickest layer of the rectus sheath. Okay. So if we have to revise once again, the rectus sheath is divided into three layers. The costal margin. So there we studied that it was only the external oblique muscle. Next is in between the xiphoid process. In between the xiphoid process, midpoint between umbilicus and the pubic symphysis. If it is here, so in this region, let us see the anterior layer of rectus sheath, which is formed by external oblique and anterior lamina of the internal oblique. Now, below that layer, below the midpoint between umbilicus and pubic symphysis, below the midpoint between umbilicus and pubic symphysis, to the region below, it is the strongest layer because it is formed by all the three aponeuroses. So the rectus sheath in this layer is very strong. Now we have discussed the anterior layer. Let us discuss the posterior layer. Posterior layer of the rectus sheath means the sheath which is behind the rectus abdominis muscle. Now, if you see the costal margin here, obviously 5th, 6th and 7th in this region, rectus abdominis muscle directly is attached. There is no rectus sheath here. You all can see here, rectus abdominis is directly attached to the 5th, 6th and 7th costal cartilage. There is no rectus sheath. Okay. Now, in between the xiphoid process and midpoint between umbilicus and pubic symphysis, in between this region, let us see the posterior layer. Obviously, it has to be formed by posterior lamina of the internal oblique and transversus abdominis. So that will form the posterior layer. Now, below, in between the midpoint and the pubic symphysis, it is, what is the fascia which is underneath the transversus abdominis? It is the fascia transversalis. So, posteriorly it is formed by fascia transversalis. So, this was about the rectus sheath. We discussed about the anterior lamina and the posterior lamina. Now we will see the contents of this rectus sheath. What is present in between the rectus sheath? There is a muscle here, which is an MCQ question. This is known as pyramidalis. It is known as pyramidalis muscle. So it is attached from the pubic symphysis and it is attached to the linea alba. This is the linea alba. So from the pubic symphysis, it is attached to the linea alba. So this is the content of the rectus sheath. In between the anterior layer and the posterior layer, you will find this muscle also. Now the MCQ question is, what is the nerve supply of this pyramidalis muscle? It is supplied by the subcostal nerve. Now all the muscles, external oblique, internal oblique, transverse abdominis, they are supplied by the anterior rami of the lower 6 thoracic spinal nerves. Now this pyramidalis is supplied by subcostal nerve, which is a MCQ question. Now another content of the rectus sheath is, see, you can see here rectus sheath being cut. What anastomosis is? Superior epigastric artery will anastomose with the inferior epigastric artery. So inferior epigastric artery anastomoses with superior epigastric artery. Your MCQ question is, inferior epigastric artery is a branch of, it is a branch of external iliac artery. You know that the aorta divides into common iliac artery at the level of L4. The common iliac will divide into external and internal iliac artery. So from the external iliac artery, superior epigastric artery will arise. So that's the MCQ question. Now we have finished the anterior abdominal wall. We will come to the posterior abdominal wall. Already discussed. We have discussed about the lumbar plexus in our last class of the lower limb. Now let us see some of the muscles here. If you see this slender muscle, that is a psoas major muscle, psoas minor muscle resting over the psoas major. This is the iliacus muscle. This is quadratus lumborum. So this is the psoas minor, psoas major, quadratus lumborum, iliacus muscle. And it's also formed by the vertebrae. Now we will discuss the MCQ question, thoracolumbar fascia. We will discuss in view of the MCQ questions asked. So you can see that the thoracolumbar fascia, so it is present in the posterior abdominal wall. Now what happens is, it is divided into 3 layers: the anterior layer, the middle layer, and the posterior layer. Okay, so this is the anterior layer, this is the middle layer, and this is the posterior layer. If you observe here, in between the anterior layer and the posterior layer, there's a muscle here which we just saw. That muscle is the quadratus lumborum muscle. Okay. Now, in between the middle layer and the posterior layer, a muscle here is the erector spinae muscle. Now, the MCQ question asked in this thoracolumbar fascia is, the anterior layer of the thoracolumbar fascia is attached to anterior aspect of the transverse process of the lumbar vertebrae, whereas the middle layer is attached to the tip of the transverse process of the lumbar vertebrae, whereas the posterior layer of the thoracolumbar fascia is attached to the spine of the lumbar vertebrae. What are the muscles enclosed in between the anterior layer and the middle layer? It is the quadratus lumborum. In between the middle and the posterior layer, it is the erector spinae muscle. And we studied, when we were studying the internal oblique and transverse abdominis, that they were arising from this fascia. So what actually happens is, the anterior layer of the thoracolumbar fascia will join with the middle layer of thoracolumbar fascia, and it will give rise to the internal oblique and the transverse abdominis muscle, which we have already seen. Now, one more MCQ question. They will ask you the nerve supply at the level of umbilicus. So, if you see here, umbilicus is at the level between L3 and L4. So, that is the level where it is present. The nerve supply here is by 10th thoracic spinal nerve. Now, if you trace about to the xiphoid process, It is by 9th thoracic spinal nerve, 8th thoracic and 7th thoracic spinal nerve. This is the MCQ question. Then if you trace below the umbilicus to the pubic symphysis, it is by 11th thoracic spinal nerve, 12th and the first lumbar spinal nerve. So the MCQ question is, umbilicus is applied by the 10th thoracic spinal nerve. Students, are you there? Are you able to hear me? Shall we answer the questions? Yes or no, students? Okay, I will discuss. The Scarpa's fascia is attached to. Scarpa's fascia is attached to. We know that. What is Scarpa's fascia? We studied that the superficial fascia in the abdomen, below the line joining the two anterior superior iliac spine. Below the line joining two anterior superior iliac spine, superficial fascia is split into two layers: campus fascia and Scarpa's fascia. So this was fatty and this was membranous, right? So Scarpa's fascia, we are talking about this Scarpa's fascia, is attached to inguinal ligament, fascia lata of the thigh, conjoint tendon, pubic crest. Any idea, students, what's the answer? Shall I continue? Okay, so Scarpa's fascia is attached to not the inguinal ligament, it is attached to fascia lata of the thigh. You remember the Holden's line, which extends from the pubic tubercle 8 centimeters laterally, wherein the Scarpa's fascia attached to the fascia lata of the thigh. So the answer is fascia lata of the thigh. True about Scarpa's fascia. It is the deep fascia of the anterior abdominal wall, also called as the Buck's fascia, attached to the iliotibial tract, forms suspensory ligament of penis. Now, Scarpa's fascia, we know that it is a superficial fascia, so it is not the deep fascia. First of all, deep fascia is not present in the anterior abdominal wall. It is called as Buck's fascia? No. What is Buck's fascia? Buck's fascia covers the erectile bodies of the penis. Is it attached to iliotibial tract? No, it's not attached to the iliotibial tract. What is this iliotibial tract? It's a modification of deep fascia of the thigh. It forms a suspensory ligament of penis. Correct. We studied that Scarpa's fascia attaches to the linea alba and it forms a suspensory ligament of the penis. In rectus sheath, which branch of aorta makes anastomosis with superior epigastric artery? In rectus sheath, we studied superior epigastric artery anastomosed with the inferior epigastric artery. So we have already discussed that aorta at the level of L4, it divides into common iliac artery. Common iliac artery will divide into external and internal iliac artery. From the external iliac artery, inferior epigastric artery will arise. So the answer here is external iliac artery, which will give rise to inferior epigastric artery, which will anastomose with the superior epigastric artery. All are true about thoracolumbar fascia except it is attached to spinous process of the lumbar vertebrae. Which one? That was a posterior lamina. Attached to transverse process of lumbar vertebrae, that was the middle lamina. Gives attachment to transverse abdominal internal oblique, correct. The fascia lies posterior to posterior abdominal wall. So to solve this, it is attached to spinous process of lumbar vertebrae is correct because posterior lamina of thoracolumbar fascia is attached to spinous process. It is attached to transverse process of lumbar vertebrae. It's correct because middle layer of thoracolumbar fascia is attached to the transverse process. It gives attachment to the transverse abdominis and internal oblique, correct, because the anterior lamina of the thoracolumbar fascia, where it joins with the middle lamina of the thoracolumbar fascia, from here it gives rise to two muscle, transverse abdominis and the internal oblique. So the wrong answer is this. The fascia lies posterior. That's the wrong answer. True statement about the lower 1/4 of the anterior abdominal wall. We are talking about the lower 1/4, that is below the umbilicus. We studied the umbilicus and the pubic symphysis midpoint. We are talking about this point. Linea alba is polyformed here. Rectus abdominis is divided. Two layers of rectus sheath is present. External oblique muscle is poorly developed. External oblique muscle is well developed. The answer to this is, in this region, linea alba is not very strong. And also, we already discussed while discussing external oblique muscle, it is poorly formed in this region. So that is the answer. Now, rectus abdominis muscle is inserted too. We already discussed rectus abdominis had two heads. Pubic symphysis was the medial head. Pubic crest and pubic tubercle was the lateral head. It arised from that and it inserted into the xiphoid process. It also inserted to the 5th, 6th and 7th costal cartilage. So the answer here is xiphoid process. Pyramidalis muscle is supplied by, what is pyramidalis? It's a content of the rectus sheath. So we already discussed it's supplied by the subcostal nerve. The posterior wall of the rectus sheath below the level of anterior superior iliac spine is formed by internal oblique, transversus abdominis, lacunar ligament, fascia transversalis. Obviously, it will be the fascia transversalis because at that level, posterior wall, there's nothing because all the three aponeurosis have formed the anterior layer. So, posterior layer is the fascia transversalis. Neurovascular bundle in the anterior abdominal wall. What are the three muscles we have? External oblique, internal oblique, transverse abdominis. Neurovascular bundle passes in between the internal oblique and the transverse abdominis. So the answer is it passes in between internal oblique and transverse abdominis, which now supplies the skin around the umbilicus. We have already discussed umbilicus was supplied by the 10th thoracic spinal nerve. Now we will discuss the celiac trunk and its branches. Is any students present? Are you able to hear me? Okay, I will start discussing. So first we have the aorta. So this aorta, we know that it's a continuation of the descending thoracic aorta. It comes out via the aortic opening of the diaphragm, which is at the T12 level, and it ends at L4, forming the common iliac artery, which later divides into external and the internal iliac artery. Now, today we are discussing the celiac trunk, which is the ventral branch of the aorta. In the ventral branch, we have the celiac trunk, we have the superior mesenteric artery, and we have the inferior mesenteric artery. So today we'll be discussing the celiac trunk and its branches. So celiac trunk, it arises at the level of T12, and another MCQ question, it is surrounded by celiac plexus of nerves. Now let us see the branches. So this is the celiac trunk here. It mainly gives three branches. What are the branches? You have the left gastric artery. Left gastric artery. Then you have the common hepatic artery. And then you have the splenic artery. So these are the three branches. So what are the branches of celiac trunk? Three branches we discussed. The left gastric artery, common hepatic artery, then the splenic artery. MCQ questions have been asked on this. So please pay attention. So first we'll discuss about the left gastric artery. So left gastric artery, it arises from the celiac trunk and it passes upwards and to the left. You can see it is passing upwards and to the left. It reaches the cardiac end of the stomach. It gives few esophageal branches to the esophagus and the cardiac end of the stomach. It travels in the lesser omentum at the lesser curvature of the stomach, and it anastomoses with the right gastric artery, which is a branch of common hepatic artery. We will discuss that later. So once again, I will revise this. So we discussed about the left gastric artery. So left gastric artery, this left gastric artery, it's a small branch of the celiac trunk. It passes upwards and to the left. Once it reaches the cardiac end of the stomach, it gives esophageal branches. It travels in the lesser omentum at the lesser curvature of the stomach, and it will anastomose with the right gastric artery. Now, one more MCQ is left gastric artery gives major contribution blood supply to the stomach. Excuse me. So that was about the left gastric artery. Now let's study about the common hepatic artery. So we are studying about the common hepatic artery. If you observe here, common hepatic artery, it is much thicker than the left gastric artery. It passes to the right. It gives a branch which is the right gastric artery. We just now discussed that the right gastric artery will anastomose with the left gastric artery. So one of the branch is the right gastric artery. Later, it gives two terminal branches, hepatic artery proper and gastroduodenal artery. We will discuss it once again. We were discussing about the common hepatic artery. We said the common hepatic artery passes to the right. It gives the right gastric artery. It gives hepatic artery proper, and it gives the gastroduodenal artery. Now, what happens to the hepatic artery proper is it reaches the liver and it divides into right and left hepatic arteries. From the right hepatic artery, cystic artery will arise. This is a MCQ question. Cystic artery arises from the right hepatic artery. It gives rise to the cystic artery. Now, we will discuss about the gastroduodenal artery. Gastroduodenal artery divides into superior pancreaticoduodenal artery and right gastroepiploic artery. So, it divides into right gastroepiploic artery, superior pancreaticoduodenal artery. Now, superior pancreaticoduodenal artery will divide into anterior and posterior superior pancreaticoduodenal artery, which will anastomose with anterior and posterior branch of inferior pancreaticoduodenal artery, which is a branch of superior mesenteric artery. We will discuss about it later. Now, we have the right gastroepiploic artery, which will anastomose with the left gastroepiploic artery at the greater curvature of the stomach. Now, quickly we will revise once again the common hepatic artery because many branches are there. We discussed that common hepatic artery passed to the right. It gave the right gastric artery. Then it gave the terminal branches hepatic artery proper and gastroduodenal artery. What happened to the hepatic artery proper? It reached the liver and it divided into right and the left hepatic artery. Cystic artery arised from which hepatic artery? Right hepatic artery. Now coming to the gastroduodenal artery, it divided into superior pancreaticoduodenal, right gastroepiploic artery. From the superior pancreaticoduodenal, anterior and posterior superior pancreaticoduodenal arteries arise. Now right gastroepiploic artery on the greater curvature of the stomach, it anastomosed with the left gastroepiploic artery, which is a branch of the splenic artery. Now we will discuss the splenic artery. Many MCQ questions have been asked on this. So, the very tortuous and thickest branch of the celiac trunk is the splenic artery. This is a MCQ question. Now, what are the branches of the splenic artery? It gives various pancreatic branch. It also gives short gastric arteries. It gives short gastric arteries. One of the pancreatic branch which accompanies the duct of the pancreas is known as arteria pancreatica magna. So this is an MCQ question. Again, that's a branch of splenic artery. It will give rise to hilar branches to the spleen. So all these are the branches of the splenic artery. It also gives rise to left gastroepiploic artery, which anastomoses with the right gastroepiploic artery. So that is about the celiac trunk and its branches. Now we will identify the branches. This is the celiac trunk. If you are seeing, this is the left gastric artery. This is the esophageal branch of the left gastric artery. Left gastric artery in the lesser curvature of the stomach, anastomosing with the right gastric artery. Right gastric artery is a branch of the common hepatic artery. We studied common hepatic artery divides into hepatic artery proper and gastroduodenal artery. Hepatic artery proper divides into right and the left hepatic artery. Cystic artery arises from the right hepatic artery. Now, gastroduodenal artery divided into right gastroepiploic artery, which anastomosed with the left gastroepiploic artery, which is in turn a branch of splenic artery. Now, this what we are drawing here, that is the gastroduodenal artery, which gave superior pancreaticoduodenal artery, which will give rise to anterior and posterior superior pancreaticoduodenal, which will anastomose with anterior and posterior branch of, if this is superior, this is inferior pancreaticoduodenal artery, which is a branch of superior mesenteric artery. Now we will trace the branch of the splenic artery. The splenic artery is very tortuous and largest branch. It gives rise to several pancreatic branches. It gives rise to short gastric artery. It gives rise to hilar branches. And it gives rise to the left gastroepiploic artery. So these are the branches of the celiac trunk. All are branches of splenic, all are the branches of splenic artery except short gastric, ilar, arteria pancreatica magna, right gastroepiploic artery. Right gastroepiploic artery was actually a branch of gastroduodenal artery, whereas short gastric artery is a branch of splenic, ilar artery is a branch of splenic, arteria pancreatica magna is a branch of splenic artery. Which of the following artery is a direct branch of gastroduodenal artery? Right gastric artery, left gastric artery, inferior pancreaticoduodenal artery, right gastroepiploic artery. We studied that gastroduodenal artery. So we will trace that. We studied common hepatic artery gave rise to right gastric artery. It gave rise to hepatic artery proper, gastroduodenal artery. Gastroduodenal artery gave rise to superior pancreaticoduodenal artery and right gastroepiploic artery. So the direct continuation of the gastroduodenal artery is the right gastroepiploic artery. The gastroduodenal artery is derived from, it is the hepatic artery. Yes, the gastroduodenal artery is derived from hepatic artery, common hepatic artery. True about splenic artery, smaller than left gastric artery? No, the smallest was the left gastric, whereas splenic is the largest. It gives short gastric artery. Yes, it curves around the fundus, arises from abdominal aorta. Answer is, it gives short gastric artery. And splenic artery is the largest branch of the celiac trunk. So this is about today's class. If you have any doubts, kindly mail me to my email. My email ID is there. Thank you so much, students. Any doubts, students? Okay, so we can end the class now. Any doubts, kindly mail me and I will clarify your doubts. Thank you so much.